Good morning. My name is McKenzie. I currently reside in Oregon, where I attend Oregon State University, studying biology and chemistry as applied to human health. Today, we will be investigating the changing landscape of healthcare, from traditional office visits to virtual health environments. Then we will be analyzing where barriers may occur in accessing telehealth to ensure post-COVID-19 era is equitable. So first off, I'd like to introduce you and welcome you to the year 2020. As I'm sure you have noticed, it's looking a little different from previous years. One where our world has become largely more reliant on technology, even more than before. From K through 12 education to family gatherings to healthcare visits, virtual meetings are becoming the new normal. During this haste transition, it is important that the evolution of healthcare in particular does not increase gaps in accessibility. The innovation curve should not act to reinforce the social gradient of health, but look to reform and provide for all. While social limitations have been put in place constricting access to public places and gatherings, the United States was not entirely unprepared in a virtual-based health foundation. In fact, telehealth has already been on the rise. This longitudinal study was created with RStudio following a conversion of percentages to numbers from census information and American Hospital Association data. From 2010 to 2017, there has been an increased adoption amongst hospitals. To get perspective from these numbers from one of the original sources, which is the American Hospital Association, there's over double the amount and percent of hospitals that utilize partial or full telehealth in 2017 as compared to 2010. This is a sizable growth and can actually also be seen when investigating market value of telehealth services. But another question is, how does telehealth work? It takes two sides supported by technology. So then the natural question becomes centered around who has access to the technology from home. A bar graph was created with RStudio from a total United States household survey, investigating how many households have a computer, which includes a smartphone, and how many have internet. Truly, the most optimal data would have not been an either-or situation, but an inclusive situation where it looked at how many people have both a computer and internet access rather than either a computer or internet access. Further, you can even go deeper into information layers by investigating what type of internet is being used and serviced. Are they broadband, dial-up? Because some are more reliable than others. Some may not actually support telehealth either. So that's something that can be looked at in the future. So why is it even important to make sure care is still being provided during these times? Since COVID-19 erupted, there has been a large deficit in overall visits. I have witnessed this reluctance of in-office visits within my own community while being a caregiver and working within healthcare research. The thing is that even though COVID is around and it's very important to deal with that head on, there are also lots of other health issues and situations that need to be taken care of and looked at and prevented. So this study looks at an ambulatory practice, and as you can see, there's actually an initial large deficit in care and visits at this ambulatory center. And this goes by the weeks and the visits, and as you can see, the gap actually decreases. So people started coming in more towards the end of June. This is a second case study that looks at the transition to telehealth at a primary care practice in response to COVID-19. Overall, the total count of visits is still lower, as you can see, and that's concerning because that means people are forfeiting their visits for some reason. And so we ask the questions, who's not coming? Who's choosing not to substitute their visit with a telehealth visit? And also, how can this be changed so that people are still continuing their health practice? So then we ask, what populations are most at risk of telehealth becoming a barrier? So we look at this through a data-informed lens, and we know that telehealth requires access to technology and the hospital or provider utilizing a telehealth services, which means that they must be equipped as well. Investigating the first determinant, we look at who has access to technology and internet at home. This can be broken down into so many layers of different social categories. For instance, this is using age and usage of technology, and you can even then look at studies that show health literacy rates, technology literacy, because that all starts to play a big role in telehealth when you become more independent over your own health information. And then you can see how those play a role in populations as a barrier also. This chart was created with RStudio and data from Pew Research, showing that 18 to 29-year-olds reliably use internet more, with just over 60 to 70% of those over 65. The second determinant looks at utilization of telehealth by provider, and data should be collected on geographical areas where telehealth is utilized. From there, it can be noted where there are larger discrepancies in populations serving hospitals and if they have telehealth. So those should become the priority. If they're serving a large population and they don't have telehealth services implemented, that's where policy should be looking to first implement scaling of telehealth services. And then I briefly wanted to mention some of the obstacles in studying this topic. One being that it was rather difficult to find raw data sets and having to rely on proxy data, or determining values from percentages with different sources combined as one of the first studies I showed. Of course, the situation surrounding COVID changes very quickly, almost day to day, and that is a real challenge for present data and understanding trends, and also the role of telehealth in the future if it will be as important as it is now. Future directions include continuing to collect data during this time, finding data on rural health systems, and then once those have been found, the initiative really becomes more focused around determining the greatest barriers and populations at risk through data analysis, and then implementing scaling of services and continuous improvement, which includes finding out how to better provide care and information for gaps in literacy